So here, this is the cortex and this is the medulla. And again, the same as we mentioned about the pituitary gland. So please make a table, the adrenal cortex, with different layers of the adrenal cortex. We have the glomerulus layer, right? Zona glomerulosa secrete what hormone? Aldosterone. Then the other layer, they secrete the zona fasciculata, secretes the steroid hormones, and then the zona reticularis, the innermost, secrete the sex hormones. Not steroid hormone, the middle layer, zona fasciculata, secretes the cortisol, corticosteroids, cortisol. And the inner layer, the zona reticularis, secretes sex hormones. That's about the adrenal cortex. So the outer layer secretes aldosterone, the middle layer secretes corticosteroids, the inner layer secretes sex hormones. Then we come to the adrenal medulla, the innermost part of the adrenal gland, adrenal medulla, secretes catecholamines, epinephrine and norepinephrine. These catecholamines, norepinephrine, epinephrine and epinephrine. Other name, adrenaline and noradrenaline. So when we say adrenal insufficiency, we mean that the adrenal gland is not secreting the normal level of its hormones. And we call that Addison disease. Addison disease. So when the adrenal gland is not secreting its normal level of its hormones, we call that adrenal insufficiency or Addison disease. Now, Addison disease, so there is no enough secretion of aldosterone. Now, aldosterone, as I told you, when you make the table for the hormone, the target organ. What's the target organ for aldosterone? Distal tubules of the kidney. What is the function? To retain sodium. To retain sodium. And when you retain sodium, along with that, you retain what? Water. So when there is no enough aldosterone, then you are not retaining water. You are not retaining sodium. So these patients, they will lose sodium. And they will have low blood pressure and low sodium. So part of Addison disease that will have low sodium and low water. Now, when we talk about the causes of Addison disease, there are acute causes and there are chronic causes. What are the acute causes that can affect the adrenal gland? Acute causes. Infection. And there is a particular infection with Neisseria, you know the bacteria Neisseria that can cause meningitis. So this, whenever there is Neisseria infection, some patients who develop Neisseria meningitis, they have damage or ischemic necrosis, hemorrhage in the adrenal gland. So some of the patients who develop Neisseria meningitis, they also develop damage to the adrenal gland because of hemorrhage. They start bleeding from everywhere, including the adrenal gland. There will be bleeding in the adrenal gland that will destroy the adrenal gland. And you can appreciate that this is called, there is a name for this. And I want to remember the name. It's Waterhouse-Friderichsen syndrome, where it is. It is written here. 74? Yes. Here. So please remember Waterhouse-Friderichsen syndrome, and these patients, they develop damage to the adrenal gland, very low blood pressure, they will have DIC, hemorrhage everywhere, and they lose a lot of fluids, and can be a fatal disease. So that's about acute, so it can be because of infection. What about chronic causes of adrenal insufficiency? In the past, and still in other countries other than the United States, the most common cause of chronic adrenal insufficiency is tuberculosis, TB. TB. The most common cause of a chronic adrenal gland insufficiency is TB. But in the United States, the most common cause of adrenal gland insufficiency is autoimmune disease. This is called lymphocytic adrenalitis. Autoimmune lymphocytic adrenalitis. But worldwide, the most common cause is TB. Other causes, cancer, metastasis to the adrenal gland. Another cause, patients with hemochromatosis. You remember that this morning about patients that they have abnormal excessive absorption of iron. The name of this condition is called hemochromatosis. They have excessive absorption of iron. So the iron level in the blood very high. The iron will be deposited because it is high, will be deposited in the heart, in the pancreas, in the adrenal, everywhere. So when this iron is deposited in the adrenal gland, it will damage the adrenal gland. So please remember this condition as well. So we have primary causes, meaning primary causes, the cause is within the adrenal gland. Then we have secondary causes, non-primary causes, that comes from somewhere else. So anytime that you have low secretion of ACTH, there will be no stimulation to the adrenal gland, right? We said ACTH from the anterior pituitary will stimulate the secretion of cortisol from the adrenal. So if the pituitary is not working, if the ACTH production is not enough, then the adrenal gland will not be enough stimulated. There will be low production of cortisol. The other way is the other way. If there is excessive secretion of ACTH, there will be also excessive secretion of cortisol. And this is the mechanism for Cushing's syndrome. So anytime that there is trauma to the adrenal gland, not to the pituitary, but to the hypothalamus, there is surgery, there is damage from whatever cause that can lead to Addison disease. Now, what I want you to understand about congenital adrenal hyperplasia. Now, remember this table. You don't need to remember the details. No, I don't want you to remember the details. But just remember that it all starts from cholesterol in the top. This is one thing. That all hormones of the adrenal cortex are made initially from cholesterol. There are two important enzymes that are very, very important in creating a condition called congenital adrenal hyperplasia. What we mean by this? One is 21-hydroxylase deficiency, and the other one is 11-hydroxylase deficiency. I want you to know that the most common cause of congenital adrenal hyperplasia, the most common cause is 21-hydroxylase deficiency. Let's see from this diagram. So look at this. So the 21 hydroxylase is here. All right? So when this enzyme is deficient, all the steps that come after that will not take place. Right? Do you agree?
Yeah.
So if 21-hydroxylase is deficient, all the steps that come after that will not take place. What does that mean? That there will be no production of aldosterone. No production of aldosterone. So what are the clinical manifestations now? So based on our understanding of the function of aldosterone, that it retains sodium and retain water. So patients who have 21-hydroxylase deficiency, they will not produce aldosterone, and these people, they cannot retain sodium. So sodium will be secreted in the urine. What will happen to the blood pressure, high or low? Very good. So these patients will have low blood pressure, or they call it salt wasting. Salt wasting. So people with 21-hydroxylase deficiency will have low blood pressure because of salt wasting. This is one part of it. The other part of it. So here 21-hydroxylase deficiency, so there will be also no production of cortisol. There is no production of cortisol. So what will happen? All the metabolic process will shift all the way to this side. So there will be production of androgens. So in 21-hydroxylase deficiency, because of the deficiency of the enzyme 21-hydroxylase, there will be shift to the production of androgens. So now we understand that these patients, they will have salt wasting, low sodium in the blood, high sodium in the urine, right? And they will have high level of androgens. Now, I want you to understanding, if this is a female child with high level of testosterone, so this is what we call, what do we call? Masculinization. Masculinization of female children. So this female will have, genitalia more or less like a male, enlarged clitoris and all that stuff. So please remember, masculinization of female fetus because of high level of androgens. High level of androgens. So this is 21-hydroxylase deficiency. This is the most common. This is the most common deficiency or the most common cause of congenital adrenal hyperplasia. The other deficiency is 11-hydroxylase deficiency. So the 11-hydroxylase deficiency is the other one. We go back. The 11-hydroxylase deficiency. 11-hydroxylase deficiency. So all those steps below will not take place. The same thing that they will be moving towards this side, producing androgens, but with one difference. And this 11-hydroxylase, this is already produced because this is not affected by this deficiency. You understand? So this one, 11-deoxycorticosterol, it has some mineralocorticoid effect. Mineralocorticoid effect, what does it mean? It can retain sodium. It can retain sodium. So please remember now, the only difference between 11-hydroxylase deficiency and 21-hydroxylase deficiency is that 21-hydroxylase deficiency, they will have low blood pressure. These people will have high blood pressure. The rest is the same. You understand that? Oh. Yeah, this is 11-hydroxylase deficiency. Now, when we talk about a tumor secreting aldosterone, we call it primary hyperaldosteronism. That is a tumor secreting aldosterone. That is primary. But what about secondary hyperaldosteronism? What is this condition? It occurs when there is little blood supply to the kidney, low perfusion of the kidney, so the kidney will secrete a substance called renin. That renin will stimulate aldosterone. So please remember the difference between primary and secondary. In primary, aldosterone is high, but renin is normal or low. In secondary, both are high. Please remember this one. The difference between primary hyperaldosteronism, which is due to a tumor producing aldosterone, the aldosterone will be high, it will suppress renin. But secondary hyperaldosteronism is because of low blood supply to the kidney, leading to secretion of the kidney by renin. Renin will stimulate aldosterone. Why? Because aldosterone will retain sodium, retain water, so that it will replenish the low level of blood in the body, and there will be more blood coming to the kidney. Now, Cushing syndrome. Now, I want you to understand the Cushing syndrome. We explained about the Cushing syndrome before, but basically, Cushing syndrome. If you are asked, what is the most common cause of Cushing syndrome? What is the most common cause? We said in the past, exogenous steroid. Physicians giving high level of steroid to patients. That is the most common cause of Cushing syndrome. Or other causes. That pituitary gland secreting ACTH. Right? ACTH, the target organ for ACTH is adrenal gland. So the ACTH from the pituitary will stimulate the adrenal gland to secrete what? Cortisol. That is another cause of Cushing syndrome. Or cancer of the lung by something called paraneoplastic syndrome. Sometimes, some cancers in the lung, they secrete ACTH, stimulating the adrenal gland to secrete cortisol. That's another way. Fourth way, the adrenal gland itself having an adenoma secreting high levels of cortisol, and that also will lead to Cushing syndrome. Is that clear? So the most common cause, exogenous, from outside. We are giving steroid to the patient for some disease, generally lupus. We treat lupus by high doses of steroid. That the complication of this, the side effect of giving high doses of steroid, patients will develop Cushing syndrome. Another cause, as we said, that the pituitary gland may be secreting ACTH, stimulating the adrenal gland to secrete cortisol. Or lung cancer secreting ACTH, stimulating the adrenal gland to secrete cortisol. Or the adrenal gland itself, independent of anything else, the adrenal gland itself is having a tumor secreting excessive amount of cortisol. How can we differentiate? The important and this is bold question. How can we differentiate based on this understanding between a Cushing syndrome because of problem in the pituitary gland or a problem in an ectopic cancer from the lung secreting ACTH or a tumor in the adrenal gland secreting cortisol? How can we differentiate? The answer is high-dose dexamethasone test. High-dose dexamethasone test will help you to differentiate between Cushing syndrome because of pituitary or Cushing syndrome because of lung cancer secreting ACTH, or an adenoma of the adrenal gland secreting cortisol. How? You give these patients high dose of dexamethasone, 2 milligrams every 6 hours for 2 days. Then you measure the cortisol level. If in this patient the cause of Cushing is an adenoma from the pituitary secreting ACTH, this high dose dexamethasone test will suppress cortisol level. So, if cortisol level, when you measure it, after giving high dose of dexamethasone for 2 days, and then you measure the cortisol level in the blood of this patient, and the cortisol level is suppressed, then definitely it is Cushing syndrome because of pituitary gland. Clear? If this dose, high dose dexamethasone test, does not suppress after 2 days, giving it 2 milligrams every 6 hours of dexamethasone for 2 days, measuring the level of cortisol in the blood on the 3rd day, if this level is not suppressed, then the possibility is of 2. Either it is a lung cancer secreting ACTH or an adrenal adenoma secreting cortisol. Then the point comes, what would you do next? How can you differentiate? Because both will not be suppressed by high dose dexamethasone test. Then lung cancer secreting ACTH and the adrenal adenoma secreting cortisol will not be suppressed. The cortisol level in these 2 conditions will not be suppressed by high dose dexamethasone test. Then what we do next? What we do next, we measure the ACTH level. We measure the ACTH level. In an adenoma from the adrenal gland secreting cortisol, what will be the ACTH level? Low or high? Low. The high cortisol from the adrenal gland will suppress the ACTH level. But an ACTH, a cortisol, high cortisol level by a lung cancer secreting ACTH, stimulating this, the ACTH will be high. Is that clear? So this is what is important about Cushing syndrome, to know the different mechanisms by which patients can develop Cushing syndrome and how can we differentiate between the different conditions. Now the adrenal medulla. The adrenal medulla, we said that it secretes the adrenaline and noradrenaline. What is important about adrenal medulla? Understanding that it secretes these adrenaline, noradrenaline, which we call catecholamines, is the pheochromosome. Please understand pheochromosome. I need you to know, when we say pheochromosome, to know that this is a tumor of the adrenal medulla. And this tumor secretes what? The same hormones of the adrenal medulla. Meaning it secretes adrenaline and noradrenaline. And since you know that adrenaline and noradrenaline, they are catecholamines, so their function is what? They increase the blood pressure. They cause vasoconstriction. They increase the heart rate. So you need to know. So what do you expect? Patient with pheochromocytoma to have high blood pressure. Is there any characteristic finding about high blood pressure in these patients? Yes. Now, what you know about blood pressure in general, in the public, when it is without any specific cause, the blood pressure will be high all the time. unless you treat it. But the blood pressure, because of pheochromocytoma, has a different characteristic. Meaning what? It goes into spikes. So that's important. When you are given a scenario about a patient with blood pressure, and you are told this buzzword, that the blood pressure goes into spikes, goes up and down, please understand that is probably, most likely, a blood pressure caused by pheochromocytoma. This is the typical blood pressure of pheochromocytoma, that is spiking blood pressure, goes up and down. The other thing that I need you to know about pheochromocytoma, it has something called the 10%. 10%. 5 things about 10%. One, the first 10%. 10% of the time, it can be seen outside the adrenal medulla. Another 10%, 10% of the time is seen in children. The third 10%. 10% of the time it can be bilateral, seen in both adrenal medullas. Fourth 10%. 10% of the time it can be malignant. Number 5, 10% of the time it runs in feminist. So please remember the 10% rule of pheochromocytoma also. The other thing that I need you to know about pheochromocytoma, that is Minn syndrome, which I told you about when we talked about the apparatus. The Minn syndrome, multiple endocrine neoplasia. Multiple endocrine neoplasia. That is the short form of MIN. Multiple endocrine neoplasia. So we have pheochromocytoma, as you see, in MIN 2B and 2A. We both have pheochromocytoma. In MIN 2A, the pheochromocytoma is seen with medullary thyroid carcinoma and parathyroid hyperplasia. In MIN 2B, is seen in medullary thyroid carcinoma, but also is seen in mucosal neurons. So please remember that if there is an association with parathyroid hyperplasia, it is MIN 2A. If there is mucosal neurons, it is MIN 2B. We talk about the parathyroid gland. So the parathyroid gland, they secrete what? Parathyroid hormone. I want you to know that parathyroid hormone, it causes increased level of calcium. How does it do that? By acting with the bone, it causes bone resorption. The calcium will come out of the bone and will be hydrated by the parathyroid hormone. It can act on the kidney by making vitamin D. So parathyroid hormone will act in the kidney to make vitamin D. Vitamin D will increase the absorption of calcium from the intestine. So this is how parathyroid hormone increases the level of calcium. And just showing you here, so don't worry about this, just I want you to understand that parathyroid gland, they secrete parathyroid hormone, and the function of parathyroid hormone is to increase the calcium level. How it increases the calcium level? By acting on the bone to release calcium and to act on the kidney to make vitamin D. Vitamin D will increase intestinal absorption of calcium. That's what I want to understand. Now this process is controlled by a gene. This gene is called calcium sensing receptor. Calcium sensing receptor. This is present in the parathyroid gland, and it's also present in the kidney. What does it do? It is very sensitive to the level of calcium. When the level of calcium is high, it will suppress the parathyroid hormone. When the calcium level is low, it will stimulate the parathyroid hormone. Okay? So this is the role of this. Now, so this is, about this. So parathyroid adenoma, there will be secretion of the parathyroid hormone. So parathyroid adenoma is the most common cause of hyperparathyroidism. And now, because you know the function of parathyroid hormone, what do you expect? The main finding in patients with hyperparathyroidism to have hypercalcemia. This again, Lynch syndrome comes here. I want you to know when we talk about, so the primary hyperparathyroidism, we said that it is a tumor secreting parathyroid hormone leading to hypercalcemia, and we know the parathyroid hormone function increase the calcium. We understand. What about secondary hyperparathyroidism? I want you to understand secondary hyperparathyroidism. If you are asked about the most common cause, please make a note. The most common cause of secondary hyperparathyroidism is kidney failure. Kidney failure. Why? When we have kidney failure, the calcium is low. The calcium is low because I told you that the kidney makes vitamin D. Vitamin D increases the absorption of calcium. So when the kidney is damaged, there's no formation of vitamin D, and there's no increased absorption of calcium, and therefore the calcium level will be low. This is one mechanism. Second mechanism, in kidney failure, the phosphate will be high. High phosphate will suppress calcium. So I want you to understand, in kidney failure, the calcium level is generally low. So what will this do? Low level of calcium, chronic hypocalcemia. What will it do? It will stimulate the parathyroid hormone. So that will result in secondary hyperparathyroidism. Is that clear? So please remember that the most common cause of secondary hyperparathyroidism is kidney failure, as I explained to you all. There are, of course, other causes. This condition, I want you to understand this condition. Familial hypocalciuric hypercalcemia. Familial runs in families. Hypocalciuric, low level of calcium in the urine. Hypercalcemia, high level of calcium in the blood. How does it happen? Yes, you remember that we mentioned that there is a receptor called calcium sensing receptor. This calcium sensing receptor is present in the parathyroid tissue, present in the kidney. So anytime there is low level of calcium, it will tell the parathyroid hormone, the parathyroid gland to secrete more of the parathyroid hormone. And if there is high level of calcium, it will tell the parathyroid gland to stop secreting the parathyroid hormone normally. But if there is a mutation, if there is a defect in this receptor, calcium sensing receptor, which is present in the kidney as well in the parathyroid gland, when there is defect in this receptor, so the high level of calcium will not suppress the parathyroid hormone. You understand that? So the parathyroid hormone will continue to be secreted and cause a great absorption of calcium. So the calcium is high in the blood, low in the urine. This is the condition. Familial hypocalciuric hypercalcemia. Please remember that the pathology, the etiology is a mutation in the calcium sensing receptor. You need to know what is the lab finding in this condition. The lab finding, calcium in the urine is low, calcium in the blood is high, and the parathyroid hormone is high or low? High. So please remember the lab finding in this condition. The etiology and the lab finding. Is it clinically significant? Does it need a treatment? No. So all what we need to know about this condition are these things. It is not clinically significant. It runs in families. The problem is in the calcium sensing receptor, and the lab finding, calcium in the blood will be high, calcium in the urine will be low, and the parathyroid hormone will be high. Hypercalcemia of malignancy. Is it in the study guide? Yes or no? No? Alright. So for this parathyroid gland, few things that I want to emphasize, and I told you about this, so that will save a lot of time for you. And the last thing that we will talk about, the so the pancreas, what's that? Yeah, but I'm just finishing in 10 minutes. Okay. So we talk about diabetes mellitus. I want you to understand here when we talk about this. And we'll talk about the tumor of the pancreas. We talked this morning about that. So I just want you to know about diabetes mellitus. That there are two types. Type 1 and type 2, okay? And we have comparison here. So please remember that this is the comparison between type 1 and type 2. I want you to know this. So that you need to know. And I want you to know that diagnosis, what is the level when we say that this patient is having diabetes. Now, anytime that you have, how we diagnose? Diagnose diabetes anytime that we measure the glucose, if it is more than 200, not fasting patient, anytime you measure the glucose in the blood on 2 occasions, and it is more than 200, this patient is having diabetes. A fasting patient, somebody fasting, after 8 hours, if you measure the glucose and it is more than 126 milligrams on 2 occasions, he has again diabetes. Or there is something called hemoglobin A1C. What is this hemoglobin A1C? Let me explain to you this for your understanding, even when you deal with patients, you deal with your relatives. Somebody with having diabetes. High level of sugar in the blood combines with hemoglobin. Some part of that will combine with hemoglobin. That's called hemoglobin A1C. The amount of hemoglobin that is generally combined with glucose normally should be less than 6.3. Any time that it is more than 6.3, this patient has diabetes. Okay? So forget about the 2-hour glucose after. So please, how you diagnose? fasting more than 126, or any kind random time more than 200, or hemoglobin A1C more than 6.3. This is how you diagnose diabetes. And the comparison between type 1 and type 2. I want to explain to you for your understanding about what we mean by insulin resistance. You know, insulin generally is secreted by pancreas, as you know, by these islets of the pancreas to lower the glucose level, particularly when we eat the heavy meal, rich meal, to lower the glucose. But you need to understand how does insulin perform this function. Insulin needs receptors on the cell wall to attach to these receptors and go inside the cell to bring down glucose. What happened in certain individuals who have hereditary diabetes in the family, with time, with aging, the receptors on these cells, on the cell wall, they become less and less. So the insulin cannot go into the cells to reduce glucose. So this is what we mean by insulin resistance. Based on this mechanism, it is found that patients who are obese, particularly those who have central obesity, big time, they found that these people, because of extra fat in their body, particularly in the center of the body, if the fat will cover these receptors, and these receptors become unavailable for insulin. That's why these patients, again, obese patients, they will have insulin resistance. So you understand the mechanism? This is what we mean by insulin resistance. So don't worry about other type, just type 1, type 2, how you diagnose diabetes, and what is meant by insulin resistance. Complications of diabetes, you know, atherosclerosis, you know, eye on the neuropathy. And we come to insulinoma. We spoke about insulinoma in the morning, right? So please remember Whipple triad, the 3 of insulinoma Whipple triad. We should remember that, and explain about that in the morning. Any questions? So, now we have finished reviewing each lecture, the main point about each lecture. So I am ready, if you want, this coming Friday, we'll just talk about the questions in general. What are the possible questions in the exam? You want to come? Yeah. I'm more than happy to be with you. If you don't want, that's your choice. And that's it about the exam. And I want to mention about Stacy. Thank you so much, Stacy. You did a wonderful job. And really, you are advocating your rights with me for everything about the exam, tough questions, challenging questions. And I thank you personally for coming all the way to help me enter into the college.